Hey, future clinicians. So today we are talking about chronic obstructive pulmonary disease. This is our short note today, so watch the video till the end. You can refresh what you have studied and learn something new from this. We're going to cover every important point. Do not skip anything. Now let's start simple. Do you know COPD is actually one of the most common respiratory diseases in the world? And the good news is it is largely preventable and also treatable. But here's the important part. COPD is characterized by persistent respiratory symptoms and something we call airflow limitation. And this airflow limitation is progressive, meaning it gets worse over time and it is not fully reversible, unlike asthma. Now, you might be wondering, what exactly causes this airflow limitation? There are two main mechanisms. First, small airway disease, also called obstructive bronchiolitis. Second, parenchymal destruction, which we call emphysema. So remember this clearly, these two processes together reduce airflow and cause COPD. Let's talk about symptoms. Do you know the most common complaint patients say? I can't breathe properly. Yes, dyspnea or shortness of breath is the key symptom. Along with that, patients may have wheezing, a chronic cough, and regular sputum production. Now let's think about causes. What is the number one risk factor? Yes, tobacco smoking. But don't forget there are other causes too. Things like environmental pollution, occupational exposure like dust or chemicals, and even genetic factors. For example, alpha-1 antitrypsin deficiency. Also, poor lung development during childhood can increase risk later in life. Now, if COPD is not managed properly, it can lead to serious complications. For example, cor pulmonale, which is right heart failure due to lung disease. Also, depression and anxiety, which are very common but often ignored. Then type 2 respiratory failure, and even secondary polycythemia. Here's something important. Have you heard about asthma-COPD overlap? This is when a patient has features of both asthma and COPD with persistent airflow limitation. And this is very important because it changes how we treat the patient. Now, let's move to treatment goals. Always remember, we are not just treating lungs, we are treating the patient's life. So our main aims are to reduce symptoms, to reduce exacerbations, and to improve quality of life. Let's start with management. First, non-drug management. The most important step is smoking cessation. If the patient is smoking, stopping it is the best treatment you can give. Also, COPD patients should be managed by a multidisciplinary team. That means doctors, nurses, physiotherapists, and dietitians, all working together. Now, do you know about pulmonary rehabilitation? This is very important for patients who are functionally limited. It includes exercise training, education about the disease, nutritional support, psychological support, and even behavioral therapy. We also teach patients how to manage sputum, for example, breathing techniques, and using devices like positive expiratory pressure devices. Nutrition is also important. If BMI is too low or too high, refer them and always monitor weight, especially in elderly patients. In some cases, surgery or interventions may be needed, but only after specialist review. Now, vaccinations. Every COPD patient should receive pneumococcal vaccine and annual influenza vaccine. Simple, but very effective. Choosing the right inhaler is very important. Always consider patient preference and their ability to use it. And remember, just prescribing is not enough. You must teach the patient and check their technique regularly. If needed, you can use a spacer, and in severe cases, nebulized therapy can be used, especially if inhalers are not enough. But continue it only if you see improvement in symptoms, daily activity, exercise capacity, or lung function. Now, initial treatment. All patients should start with a short-acting beta-2 agonist or a short-acting muscarinic antagonist when needed. Before stepping up treatment, always check, is COPD confirmed by spirometry? Are vaccinations given? Is non-drug management optimized? Is the patient using their inhaler properly? Very important step. Now, step up treatment without asthma features. First, we use a long-acting beta-2 agonist plus long-acting muscarinic antagonist. And remember, if you start a long-acting muscarinic antagonist, stop the short-acting muscarinic antagonist, but you can continue the short-acting beta-2 agonist if needed. Remember this clearly. I'm not going to go through every single medicine one by one here. My goal is simple, to help you build strong clinical understanding. Okay, next. If the patient has frequent exacerbations, we add an inhaled corticosteroid, making it triple therapy. This is usually when there is one severe exacerbation or two moderate exacerbations per year, and always review annually. If symptoms are still not controlled, you can try an inhaled corticosteroid for 3 months. If it works, continue. If not, step down. Now, if the patient has asthmatic features, we start differently. First, a long-acting beta-2 agonist plus inhaled corticosteroid. Then, if needed, add a long-acting muscarinic antagonist, making triple therapy. Now, let's talk about prophylactic antibiotics. Do you know in some patients we use azithromycin long-term, but only in specific cases like non-smokers with frequent exacerbations despite optimal treatment. Before starting, we must do tests like sputum culture, CT scan, ECG for QT interval, and liver function tests, and always review regularly. Let me ask you something. Are you a future pharmacist, a nurse, or a doctor watching this video? I'd really love to know. So make sure you leave a comment below because your comment is truly special to me. Okay, next. Now other treatments. Roflumilast, used in severe COPD with chronic bronchitis, but started by specialists. Mucolytics can help if the patient has productive cough, but continue only if there is benefit. And remember, antitussives are not recommended. Theophylline is used only if inhalers are not effective or the patient cannot use them. Also, always check mental health. Anxiety and depression are very common, and oxygen therapy should be used when indicated. Now, let's move to exacerbations. Every patient should have an action plan. They should know when to take medicines and when to seek help. Sometimes, patients keep antibiotics and oral steroids at home, but they must know exactly when to use them and inform the doctor. During exacerbations, we use short-acting bronchodilators in higher doses, nebulizer or inhaler, depending on severity. We also use prednisolone, short course, especially in severe cases. Long-term steroids? Usually not recommended, but if used, use the lowest dose and monitor for osteoporosis. In severe cases, we may use aminophylline, but monitor levels carefully. Oxygen therapy must be controlled to maintain target saturation. If the patient develops respiratory failure, we use non-invasive ventilation or even invasive ventilation in ICU. And doxapram is used only if non-invasive ventilation is not available or suitable. So let's quickly wrap up. COPD is preventable, progressive, and not fully reversible. Management includes stopping smoking, using inhalers step by step, vaccination, rehabilitation, and managing exacerbations properly. So future clinicians, if this helped you, don't forget to like, share, and subscribe. And in the next video, we will cover allergic conditions, including antihistamines, allergen immunotherapy, and allergic emergencies. See you in the next lesson. Stay focused and keep learning.